Welcome back. Why don't we get started with the afternoon session? I think this morning was really terrific. Lunch was great. After listening to Dr. Xiaoping Li, I think we hit all the high spots with the lunch, so that was good. Really excited to introduce our next speaker. Dr. Hecht is a professor of clinical medicine at UCLA and holds the Carol and Sal Rosenzweig Chair in Cancer Therapies Development. He's director of the UCLA Gastrointestinal Oncology Program. He went to medical school at Eastern Virginia Medical School, and then his internal medicine residency at Northwestern, a GI fellowship at the University of Chicago, and then also GI and medical oncology at UCLA. He's an important member of the pancreas program at UCLA and treats a variety of different types of gastrointestinal cancers. He's a lead on directing small trials with new molecules as well as large international randomized trials. So we're really lucky and looking forward to hearing his talk entitled Precision Medicine versus Standard of Care for Treatment. Dr. Hecht.
Thank you, Joe. Well, you know what? This is the first, can you hear me okay? This is the first time I'm actually going to take my mask off for this. So it's kind of like the masked speaker, but hopefully not as controversial. So let's see if I can do this. I'm far enough away from y'all. I have someone who's disabled in my household, so I try to be really careful. But it's really nice to see so many people here in person, you know, after several years of Zoom. And I know that there are people here on Zoom, but I think, Joe, you had said there are 100 people on Zoom or something like that. You're here somewhere lost in the lights, and but I want to thank, you know, the Hirschberg Foundation. I want to thank Joe, the organizers, for asking me to speak. We do all work closely together, but it's nice to do something formal. And Aggie, thank you for all that you and your foundation do. So I had a special charge, and my charge, you know, they didn't allow me to pick my own topic. So. But the more I looked at it, the more interested actually that I became. And maybe Joe came up with it, but which is Precision Medicine versus Standard of Care. And then I added the subtitle, which is How Can We Do Better? Okay, because people have come up and talked to me, and obviously, even though some people do really, really well, we certainly can do better. So let's talk a little bit about metastatic pancreatic cancer. So this is the FOLFIRINOX trial. This is the standard of care. And everything I'm going to talk about today, virtually everything I'm going to talk about today, is in the metastatic setting. Because unfortunately, you know, even though Dr. Hines and Dr. Donahue are incredibly important, as was brought up at the very beginning, I think Mark Gerges had talked about it, is that most people are not operable at the time of diagnosis. Some can be made operable, but even those people who are operable often end up with metastatic disease. So the vast majority of the people, and the vast majority of people that I see, are people who have metastatic disease. And the question is, how are we doing? So on one hand, let me make certain I push the right button. Can you see that? This is the standard of care for healthy patients. This is a major improvement over the old standard of care, and I'm old enough to remember when gemcitabine was approved. We're not doing that well. And so, because when you look at median overall survival, was still less than a year. This is an incredible unmet need. This is not the failure of the patients. This is the failure of us to not give our patients better treatments. And really what I'm going to try to say is, how can we use the treatments that we already have? And that's precision medicine we'll talk a little bit about. And also, how can we get to the next generation of treatments? So treatments that don't just last for a short period of time, but possibly treatments that may last for years. Because that's what really patients want. Patients don't want things that work for months. They want things that work for years. And so, while yes, this is what we do, and there's definitely people, we help people with this. And this thing right here, which is called hazard ratio, I'm going to try to speak lay. So raise your hand if you don't understand what I'm saying, or at least I say that maybe there are too many people here. You can talk to me later and fuss at me. But hazard ratio means that basically about twice as many people are alive at any one time point, but the curves go down. This is called a Kaplan-Meier curve. Everyone's alive at the beginning. This is time. The problem is almost everyone is not alive in a relatively short time. How can we do better? This is what we want. Unfortunately, this is not pancreatic cancer. And when I'm talking about pancreatic cancer, I also see neuroendocrine tumors of the pancreas, important disease. Everything I'm talking about is adenocarcinoma or pancreatic ductal adenocarcinoma. So this is, and I'll talk a little bit more about this later, these are patients who have an unusual genetic way to cancer, which is called microsatellites. Their tumor has a microsatellite instability or deficient DNA mismatch repair. They are exquisitely sensitive to immunotherapies, the stuff you see advertised on TV for lung cancer. Okay? This is the curve that you want here. Because if you look, not only does it go down to 20 months, this was actually from Dr. Canto's institution, Dong Li and Luis Diaz, who's no longer there. He's now at MSK, but who I've worked with. And this curves continue, so it's flat. That means people are still doing well, and it continues out to somewhere like here. And so that's what we're looking for. Unfortunately, those patients who did not have that genetic way to cancer, this happens to be mostly colon cancer patients, but this is a good way to look at it. Most of these people died relatively quickly. So how do we get to here from what I just showed you? So one of the thoughts has been, and this is not anything that's new, this is actually, in fact, in some ways, the pendulum switches. So when I started in oncology back in the, should I say, in the 90s, everything was going to be about targeted therapies. And there's an overlap between targeted therapies and precision medicine. And then we've gone to immunotherapy. So we didn't cure cancer with targeted therapies. And so the question about, and now actually the question is that maybe one of the reasons that we're not doing so well is because we're not treating the right patients with the right drugs. And maybe we're not necessarily picking the right targets. So the NCI actually has a specific definition. They're not the only people. Oops, I think I hit the wrong here. Which is a form of medicine that uses information about a person's genes. In other words, what the background is, proteins, environment to prevent, diagnose, and treat disease. And has the promise of the right drug for the right patient. Problem is we need to have the right drugs as well as the right patients. And hopefully we have better outcomes, which is what we care about most, people living longer and feeling better, less toxicity. But what exactly is the reality when I was given this charge? You know, have we really made benefit? Are we really doing better with precision medicine? And I would say right now is that yes, but there's a big asterisk there. So when we talk about genetic alterations, and that's a lot of what I'm going to talk about, because remember, genes tell you basically what proteins to be made. The proteins do all the work. The genes are the instructions for those proteins. And there are two types of mutations that we're going to talk about. Now, Dr. Canto earlier talked about what we call germline mutations. These are mutations that are found in every cell of your body. And they are generally what we talk about, like she was speaking about predisposition genes like BRCA1, PALB2, ATM. So these are in every cell of their body. Now, the tumor has any alterations that are in you because it came from you, plus other mutations that allowed it basically to be a cancer. In other words, it grows when it's not supposed to grow, it doesn't die when it's supposed to die, and it moves to places it's not supposed to move to. That's basically the definition of cancer. And roughly about 100 mutations are found in the average pancreatic cancer. So some of these mutations are early, and I think Dr. Canto showed, for example, KRAS. In the 90s, we published some early, when I was a gastroenterologist, about finding KRAS which we'll talk about in pancreatic cancers early, but it wasn't that helpful because precancers, like remember she talked about pannins and precancers also had it. So finding it didn't mean the patient had cancer. Some of these mutations don't do anything, and they're called passenger mutations. Some of them, like KRAS also, are really important and are what we call driver. These are the ones that are making the tumor grow. And finally, we also divide them up into, are they actionable, meaning I have a drug, I can do something about it? Or if you find a mutation that I can't do anything about, is that really that helpful? And the answer is, at least right now, it's helpful for saying what is the unmet need, but it isn't helpful for me treating my patient. So every patient's cancer is unique. Okay, it's unique because unless you have an identical twin, and even then they're a little bit different, your germline is different. Plus, even though the mutations are often in the same places, the patterns are such, and there's so many mutations that no one patient has exactly the same. And then I realized as I was looking through my slides, and the next question is, well, Dr. Hecht, how do I know, because I didn't put a slide in for this, what my mutations are? And we'll talk about something called next generation sequencing, and because I think that's really important in pancreatic cancer. So when we look at, can you read this? I can't read it from here, but I have my computer glasses on. Maybe I have the wrong glasses on. So basically, when you look at patients who have pancreatic cancer, you can either be a lumper or a splitter. And if you're a bit of both and split into small groups, almost all patients with pancreatic cancer have KRAS mutations, which I'm going to talk more. That's a driver to grow. I think Dr. Gerges mentioned over 90% of them have KRAS mutations. Some of them are actionable, and that was mentioned earlier about G12C, but most are not right now, and as of today. There's some other rare things, and then we'll talk mostly about what are sometimes called homologous recombination deficient or DNA repair, and that's sort of been where precision medicine has made its biggest benefit. And then the rest of them, unfortunately, are in a group of patients where precision medicine has not helped. And we're back to modified FOLFIRINOX. And this is another way of looking at it. This is a slide that I stole. And the idea is that there are all these different mutations. They also overlap, because sometimes there's a driver mutation and other mutations. And the question is that if you block the mutation that isn't the driver, probably aren't helping the patient. But we do have lots of drugs. That's been the targeted therapy revolution, that there are thousands of drugs that have been developed. The question is, will they help an individual patient? So let me talk about where it has been most helpful, and this is in DNA repair. So one of the things that's really important for a cell is to maintain the integrity of its DNA, because so on one hand, when that breaks, that's how you get to cancer. And then, for example, patients who have BRCA mutations, they are more likely to actually end up with mutations. People who have something called microsatellite instability have thousands of mutations, and by just random chance, some of those mutations actually lead to mutations that cause the cells to grow. But what we found is that in particular, the BRCAs, which are found more commonly in Jews of European extraction, or so-called Ashkenazi Jews, but are found around the world, just more commonly in that group and some other groups, plus some other DNA repair. And this is from Michael Pishvain's study, which was called Know Your Tumor. And they looked at an earlier version of next-generation sequencing. So now, to explain what next-generation sequencing is that you can look for one gene in a tumor, and that costs a certain amount of money. You can look for a couple genes in a tumor, and that costs a certain amount of money. And in fact, however, if you're going to look at a large group, there are these companies, basically, or you can do them in academic centers as well, that look at 600 different genes. They multiplex it. That's the term they use. They do it all at the same time, and then you get all this information, and they're not that expensive anymore. And so because of that, and because of the technology, sort of related to the technology that Dr. Canto talked about for cell-free DNA, being able to do that has allowed us to identify these patients. In fact, BRCA testing, germline testing, is free in some places, and as it probably should be. But these are several genes of which BRCA, make certain I have the right one, BRCA1 and 2 are the most important. I just identified a patient with a PALB2 mutation. It's unclear if these, but about 15% of these patients had alterations in DNA mismatch repair. This is actually a little bit low for KRAS, but I think this is sort of a bit of an unusual group. So when we're talking about DNA repair, there's one of the thoughts, and actually Alan Ashworth, who's now the head of the Cancer Center, was in the UK, but now at UCSF, and Lord also looked at this. And the idea is that cancer cells are partially broken. And those partial breaks allow them to grow, but it's also an Achilles heel. And the idea is that there's a lot of redundancy built in if you break something important. And if you have a cell that has, in effect, a backup, and you block one of those pathways, that cell is okay. However, if you block that pathway and it's already broken in a cancer cell, that cell dies. And that's called synthetic lethality. Because what we care about is we want to kill cancer cells and leave normal cells alone, right? And so BRCA is one of those things. And so this is sort of another way, because I only have so much time, and I have about 3 slides on this. But basically, there are several different ways to repair DNA. patients whose tumors have loss of BRCA. In other words, they've lost both copies or neither copy is working and are not great at DNA repair. If you knock out another way that would normally make up for that, those cells don't do well. And in fact, they do even worse when you give them chemotherapy as well. And this has led to what are called PARP inhibitors. Actually, I know Mark O'Connor, who was at Kudos and then at AstraZeneca. That group was one of the first to really look at. And so basically, the drug that's been looked at the most, which is called olaparib, and it blocks PARP. And so what happens is that the tumors start building up what are called double-strand breaks. However, what fixes double-strand breaks? Actually, BRCA. If you don't have BRCA, then basically the DNA gets mucked up. It's okay for the tumor to have a little bit of mucking up because those mutations, but if it's really mucked up, the cell dies, and that's what we want. And this led to, this has been really most successful in ovarian cancer, somewhat successful in certain types of triple-negative breast cancer, and this led to, I can't see it that well, but to trials with olaparib. And what you can see in the early trials is that a reasonable number of people had, when we say response, that means the tumor shrinks by, actually the tumor shrinks by much more than half. So when we say response, we really mean major response. That's not the same thing as clinical benefit. And these were in patients who had BRCA germline mutations. In other words, they inherited it. So this led to so-called POLO trial. Actually, this was presented by Hedy Kindler from University of Chicago, but Talia Golan, who's in Israel, which has a lot of BRCA mutations, actually was the senior author, and looking at this in patients with germline BRCA mutations and metastatic pancreatic cancer, and it's called the maintenance setting. Without getting too wonky, this is another PARP inhibitor. This is called a waterfall plot, basically looking, did the tumor shrink or did it grow? And the answer is about half of them shrank just with the PARP inhibitor. Looks interesting. Okay, doesn't tell you how long it was. And actually, Rachna Shroff actually published this, who was here on Thursday as a visiting professor. Now she's at Arizona. So this looked at patients, a very, very small group of people. They had to have BRCA, 5-ish%, okay? Then they were treated with chemotherapy that really is good for their. And then they said, well, you know, it's hard to be on this tough chemotherapy for a while. We would normally put you on some sort of lesser chemotherapy as maintenance. However, they said, we'll just compare it to nothing. And what it was it was better than nothing. This is what's called progression-free survival. How long did it take for the tumor to get worse? Everyone starts at 100%. Some people did well for a long time, but you're doing better than nothing, and most people aren't on nothing. So it was good that they did it, and it got it approved. And I actually, for full disclosure, I actually helped prep AstraZeneca for the FDA, and I told them I wasn't certain if they should go to the FDA, but at the end, I'll tell you why I thought that they should. Mostly, I can tell you now, mostly is because it gets people to be tested for BRCA. Well, and everyone who has pancreatic cancer should have germline testing. So I thought that was probably how it was going to help more people by saving lives, by getting them to Dr. Canto, by getting their mammograms, by getting their other things. But so this was important. This was precision medicine. But this is overall survival. This is what we care about. It wasn't that much better, though some of these people also got PARP inhibitors afterwards. So what else can we do? Actually, Eileen O'Reilly, who's been a leader in this, actually probably has helped more people with a negative trial. So what they did is that these are not the drugs we usually use. We don't use gemcitabine and cisplatin. Patients who have bad DNA repair are really, really sensitive to cisplatin. They just are, more than people who don't. So this was a trial looking at gemcitabine, which is often used, cisplatin, with or without probably a bad PARP inhibitor. Olaparib is like a terrible PARP inhibitor, but that's how the trial was done. And not surprisingly, olaparib didn't help. In fact, Zev Weinberg here at UCLA has done a number of trials combining good PARP inhibitors, and it's hard. And so what you can see is almost everyone, but this waterfall plot again, everyone's tumor shrank except for these poor people over here. And this is now the standard of care. So I would say that's precision medicine. So everyone who shows up with pancreatic cancer should have germline testing, and I would say everyone who shows up should have next-generation sequencing. Okay, are you with me so far? I just make certain that I'm explaining this right. So I'm going to talk about what are the other things that we have drugs for. I'm putting RAS off to the side because that is the 800-pound gorilla, for this. But in that 5 to 10%. There are all these other genes that are broken, that are drivers, that are telling these cancers to grow. And it's a whole laundry list. Whoops, I hit the wrong button there. Here. And the nice thing about these is almost all of these are also found in other cancers, particularly common cancers like lung cancer. So the pharma industry has spent a lot of money developing inhibitors for these. So you don't have to go ahead and invent something new. These are often in the clinic already. So they've looked at these, what are called basket trials, trying to look at these, and I'll talk real briefly because I'm looking at my time. NRG fusions, BRAF, all these but basically the problem is that while they are a small percentage of KRAS wild type, that means no mutation, just that's the term we use, to make certain patients don't understand what we're talking about. But as opposed to mutant, patient's not mutant, the tumor has a mutation. But if you look at overall percentages, it's all under 1%. Should look for, though, because we have drugs for those people. And this is one called larotrectinib. These are NTRK fusions. They are found at low levels throughout many different types of cancers. But what you can see is that if you have the right drug and you have the right, and these drugs are FDA approved, if you have the right drug and you have the right mutation, you can definitely have your tumor shrink. And even this is a PET scan that uses, this one uses radioactive sugar, and you can see the spots where the radioactive sugar lit up because they were cancers and were taking up they needed lots of energy, they all go away. And so these actually patients of all the targeted ones probably do the best for the longest period of time, but they're very rare. This is something that's also found in lung cancer in particular, so there are like 5 or 6 different drugs. I don't take care of lung cancer that are already available for this because lung cancer is common. You see the same thing. This is RET is also found in, even though if you have a RET fusion, it's common in pancreas cancer. It's rare and it's often seen in lung cancer. So we have these arrows that show the pancreas cancer patients, and almost all of their tumors shrank. And then I mentioned NRG fusions. It's uncommon, and even though basically it's still 0.5%. And this is a drug, but it takes a lot of people and a lot of time to scrape these people together because there's so few. And it's very frustrating when you have to screen 200 people to get one patient. That's why everyone should have next generation sequencing, so we can put all these people together and we can call you to say, hey, that's only if you're in Canada. You can say, hey, we found that your tumor had an NRG fusion. These are these trials that are available for you. So then let's talk about things that are undruggable. All those are druggable targets, meaning that we might be able to help you. This is actually from Jordi Rodin, who's a phase 1 person I know at MD Anderson. And the one that's important, because some of these have already been drugged, like VHL now, is KRAS. I found this online. There is actually a hotel KRAS. I think it's somewhere like in Romania or something. It must mean something different. So we're going to check into the hotel KRAS. And so KRAS is actually an important, think of signal transduction or ways that signals for cells to grow. Normal cells need signals to grow a little bit and not die periodically. But that signal needs to be short. Grow a little bit, then stop growing. And all these growth signals go through something called RAS or KRAS. There's more than one. KRAS is the most important. Right there, these are signals to grow. And the problem is that normally it gets turned on, says grow, and then it turns itself off. When it's mutated, it gets stuck in the on position. So it's like a short circuit telling the cell to grow, keep growing, keep growing. The problem is that we have not, without getting too much into medicinal chemistry, been able to block that up until about the last couple years. Now, I think as Mark Gerges pointed out, that most of the ones in pancreatic cancer are G12D. 12 is where it's broken. Codon 12, and they tend to rhyme because all the different breaks, if it breaks it and it doesn't short circuit, if it doesn't get stuck in the on position, no, it doesn't change anything. It doesn't make the cell grow. So that's why there are very specific places where KRAS is broken that causes that signal to grow. And codons 12 and 13, this just says what it gets from one amino acid to another that causes that short circuit. It happens in pancreas cancer. It tends to be G12D, G12V, G12R. All the others are pretty rare. And unfortunately, the one that we have right now an inhibitor for is G12C, which is that yellow one right in there. doesn't mean it's not important. So there have been a couple. There's an Amgen drug, AMG 510, or sotorasib, which is, it takes years of training to pronounce these things. And so sotorasib is a blocker, is the first one on the market, mostly in lung cancer, because G12C is common in lung cancer. And then when they looked, and if you have pancreas cancer, that's what those arrows are. If you have pancreas cancer and you have a G12C mutation, notice the tumors shrink. So it's kind of doesn't matter what kind of cancer you have, it's whether you have that mutation. The problem is pancreas doesn't have it that often. There's another one called adagrasib that's from Mirati. For full disclosure, I'm on a steering committee for an adagrasib trial in a different type of cancer. I've been working with that, and they also have data that looks really similar. Recently, John Strickler, who's at Duke, presented. ASCO now has these monthly plenary sessions rather than waiting all until June. This was in pancreatic cancer with this one. Notice it took a lot of people to get this 38. And what you can see, these are all pancreatic cancer patients with the waterfall plot. Probably about 3/4 of the people or more, 80% of them, had tumor shrinkage. The problem is this. It didn't last that long. And so progression-free survival, how long did it take for the tumor to grow? Median 4 months. Some people did well for a long time, and still half the people were dead at 8 months, 7 months. So how do we get beyond G12C? And with apologies to Dr. Seuss. And so I had not cleared this with the Seuss estate, so don't tell anyone I did this. And so the one that's probably most important is G12D. There are a number of companies that are looking at G12D inhibitors. I think those will be out soon and hopefully will help our patients. They're pan-RAS, meaning all RAS. We're very interested, and we're doing trials with those right now, or we'll be opening up. Generally, they work kind of how downstream and around RAS on how it amplifies this growth signal. And there are also some metabolic inhibitors, and I'm not going to talk about, but this is also a target for immunotherapies, which I'm going to finish up in the last 5 minutes and 48 seconds. These are just without going into too much detail, this is an adapter molecule. In other words, it amplifies that signal. If you block that, maybe, it's called SOS1, maybe you can actually block RAS signaling without having to block this really difficult to block molecule. Autophagy, basically RAS is really important in a number of ways. And they were talking about the metabolism before. And RAS actually has a big effect on metabolism. RAS also has a big effect in the stroma around the tumor as well. And one of the ways that cells survive in hostile environments, and pancreatic cancer is a very hostile environment, as we found out, trying to get immunotherapy cells into there, is by actually eating part of themselves, and blocking that may also be a way specifically together with other drugs to block KRAS. Stay tuned for that. So what's the problem with precision medicine? Well, one, how many patients really do have actionable mutations? I think it's clearly in single digits in pancreatic cancer right now. And then it only lasts, the other problem is it only lasts for so long. Now, that being said, we can really help those patients, and we can even help their families if it turns out it's an inherited predisposition. So I think every patient should have next generation sequencing. And if you have a doctor who has not ordered next generation sequencing, you can tell them that I'm the one who's being the pain in the tail, and they should order it, okay? Usually it's covered by insurance. If not, they'll work out some deal with you. And then, as I mentioned, the problem is how long do targeted therapies work for? Now, this is also from the Know Your Tumor, and it looks like really great, and that patients did better when they had a targeted therapy and a target and a targeted therapy. But I think most of this is due to BRCA, which we already test for. The question is, what about the others? The problem is even active drugs develop resistance. This is melanoma. I know this is a pancreas symposium, but you can see it better than on a CT scan. These same targets are found in melanoma. In fact, the tumors respond better in melanoma. And a lot of them, remember I said, we already had these drugs approved. Thank you, you other diseases, because you helped us develop these. So melanoma is dark, so you can see this is a poor guy. He's wasted away. He has all these dark dots on him. Gave him the right targeted therapy. He's buff. He's kind of redder now. The problem is it only lasts for so long. So that's the problem. And this is a problem. If you block RAS signal transduction, that's that same slide again. That's RAS. But in reality, this is really what it looks like. There are all sorts of feedback loops. So if you block here, there are lots of other signals to grow that the tumor can use. And that's the problem, what we're doing. So can we do better? Yes, clearly we can do better. And I think I'm going to finish up the last 3 minutes, sum up, with immunotherapy. So most immunotherapies, the stuff you see advertised on TV, are what are called checkpoint inhibitors. And checkpoint inhibitors, basically a checkpoint is something on a normal cell that says, leave me alone to your immune cells. Because your immune cells are designed not to pick up cancer, but to actually pick up virally infected cells, which are kind of like you, and just like cancer cells are kind of like you. But you don't want them attacking your normal cells. That's autoimmune disease, lupus, rheumatoid arthritis, inflammatory bowel disease. So they have these checkpoints on there. And in some tumors like melanoma, or as Eddie Guerin, that's what Tony Rebus helped develop here. Eddie Guerin, who ran the first trial in non-small cell lung cancer, was here. That may be all that's needed. The problem is that this is very highly regulated, and often there's more than one checkpoint. The other thing that really tells the immune system there's something wrong is how many mutations there are. Because the more mutations you have, the more broken proteins. And your immune system knows what the right proteins are. They've been educated. But if you have a mutation in a broken protein, they kind of sniff around. There's something wrong. And so basically the ones where checkpoint inhibitors work have lots and lots of mutations. Pancreas cancer is kind of over here. I got the color right. There are less than 1% of people who have that thousands of mutations. And guess what? Checkpoint inhibitors work for them, but it's less than 1%. It's still worth looking for. So I think this was already brought up before. These don't work, these checkpoint inhibitors by themselves or with chemotherapy. So what can we do? Why is this not working? Well, it turns out, as I said, pancreatic cancer is terrible for immune cells. The pH is bad. There are all these immunosuppressive cells. There's a lot of stroma, which is gristle. And so the problem is, what can we do? And this is another way, because I have 1 minute. But these are another way of saying this. This is actually stolen from Mark O'Hara, who's at Penn. Basically, all these different ways. The problem is why it's a bad place to do immunotherapy. Can we do better? So, and in fact, I ran a global trial, a phase 3 trial that was negative that we published last year. Can we do better? So let's finish up talking about cellular therapy. Cellular therapy has been one of the great advances in immunotherapy of hematologic diseases, where it's incredibly useful. These are engineered cells. You take your immune cells out, your T cells, your killing cells out, and the problem is that they're not recognizing the tumor. You find something that's on the tumor, and you basically put it in the T cell, you grow them up, and you send them on its way, and it kills all those cells that have that target. The problem is it's hard to find a target that you don't need. You can with your blood cancers. You don't need all those cells. You can make up for them, but that's the problem. The problem in solid tumors, not just pancreatic cancers, but has been that the T cells don't live for a long time. They have what's called on-target, off-tumor toxicity. What that means is that, yes, you did what you were supposed to do. You hit that target. The problem is that target was in your GI tract, or your target was in your lung. You don't want that. You want it to be cancer specific. So I'm going to finish up with something that we're working on with some of the people here in the room, which are called logic-gated CAR Ts. And can we go to the next generation? And the idea is that you have something that's missing in the cancer, but is present in normal cells. So that cell has the target. It also has something that's missing, so it's different. And there's what's called a blocker. And that blocker then allows that T cell to kill that cell. And the blocker that we're looking at, that combination, is found in pancreas cancer. If you notice, it's at the top, without getting into too much because I'm already a minute over. But this was called loss of heterozygosity, which means this thing is lost. It's something on the surface of the cell. And it's actually relatively common in pancreatic cancer, so there are lots of reasons why we want to look at it there. In animal models, we cure cancer all the time in animal models, unfortunately. But if it doesn't work in animal models, it's not going to work in people. But at least in animal models, this works really well. And the target we use is something called CEA, but there are lots of other targets. And these modified T cells are called TMOD. So we just opened a trial yesterday. And so finally, at UCLA, lots of work. It's in a couple centers around the country where we're actually screening patients to see would they qualify later on for to have their T cells basically turned into hopefully an anti-cancer therapy. We're catching these people early. We're catching them as high risk after they've seen Dr. Donahue. We're trying to identify those patients who have the genetic alterations that match with this, and hopefully this will be out. We'll be getting the word out very soon. As I said, yesterday afternoon we finally got it approved. But there are other targets we can use as well. So to finish and be over, we've made some advances. So I think, yes, precision medicine is good. But there's a huge unmet need, and of all the unmet need, unfortunately, pancreatic cancer has the most unmet need in precision medicine. I think every patient should have next-generation sequencing. It's not that next generation. I would say that it's standard of care. There are actionable mutations in patients right now that I have drugs for, okay? Just we need to find them and identify them, but even then, they only work for so long. Immunotherapy, I think, is the future. I don't want to say anything bad about targeted therapy. It helps our patients, but I think that's where we're going to end up. And as always, we appreciate all the support that people have given here and other places, because only by research are we going to do better. Thank you for your attention. Did I take up my question time, or do you have time?
No, yeah, we have a few minutes just for one or two questions if anybody has them.
Sorry, I'll be around if there's a question later. I apologize.
No worries, we are good. Alyssa has a question from Zoom, so she is heading over to the mic.
Do you see any organoids as an important tool for future precision therapy?
I only had 30 minutes, so actually I think organoids are really interesting. So first, let me explain what organoids are. We try to have models of cancer. And one of the models that we use, like some of our earlier speakers said, are cell lines, from people's cancers that are grown up, and we can test on those and do research on them. The problem is that when you grow them in plastic, like in the equivalent of a petri dish, that's not how they really are in real life. And they're really different, and they act differently. So the question is, can you get more of the three-dimensional structure of what really happens with the cancer? And there are lots of different cells in there, and those are called organoids, or little organs, like organs. And so you can get those from a tissue, and you can grow them up, and they're useful in two ways. One is that people are doing research with it that way, okay? But I think the question was, what about my tumor? And I have done that. There are people here at UCLA who are actually doing research in that as well. There's a company called Sengen that I have used that's a spinoff from University of Washington. And the idea is that you have lots of tiny little organoids, and you can grow them up quickly and test like 10 different drugs or 100 different drugs. I don't think that's standard of care yet. I think they need to prove that it does better than just saying, okay, we're giving everyone modified FOLFIRINOX. But I can't say that it's wrong, and if someone wants to do that, I'm supportive of that. There are other ways to look with our avatars where you can actually get your tumor grown up in immunodeficient mice that can also be useful. There are a number of companies that do that. Once again, I'm not certain about it's hard to do the accuracy of that. Okay, any other questions, or did I bludgeon you into
I think
submission?
we are right at the time mark. Thank you so very much.